We can start. Please start.
Good evening, everyone. It's my pleasure to invite you all to the ISA National PG Online Class event. I myself am Dr. Shirley Joseph, consultant at Joseph Specialty Hospital, Srivilliputtur. I will be a screen coordinator along with Dr. Nivedita, Assistant Professor, Narayana Medical College, Nellore, Andhra Pradesh. As we are beginning this session, I would like to quote Henry Ford. Anyone who stops learning is old. Anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. In accordance with it, ISA provides this amazing platform for the postgraduate students to absorb information, exchange views, and assimilate knowledge for them to inculcate into their daily practice. With this being said, let us commence this session by invoking the blessings of the divine as we meditate on the Saraswati Vandana. Today's topic is on the basics of capnography. Capnography has revolutionized the field of anesthesia and has become a mandatory monitoring tool in the perioperative and critical care setting. And it is of utmost importance that we as anesthetists gain in-depth knowledge about this essential monitoring tool. With this being said, I invite our ISA National Honorary Secretary, Dr. Bajwa sir, to commence this session.
Thank you, Shirley. You have made my work very easy today. You have almost said everything what capnography should be, why should be taught, and how should be taught. I think Dr. Hitel will be telling in a very, very good manner. But I think there are a lot of projects going worldwide also about the capnography projects, where it is essential for almost every operation theater and ICU. And even in our ISA national guidelines also, we have the minimum mandatory guidelines. We have put capnography as an essential monitoring tool because it has made life very, very safe and easier, especially in the difficult airways where the difficult, and the laparoscopic surgeries. You rely too much heavily on the capnography. It gives you almost 99% specificity. And going forward, but even during my days also, when I was doing the post-graduation, the interpretation, the reading, the how to analyze different situations with the capnography is very, very difficult sometimes. Sometimes you can even be able to make diagnosis also just seeing the pleth of the capnography, the graph you see, and you will be able to diagnose that this is the condition. Or sometimes you may not be able to auscultate every time the chest, or sometimes the respiratory dynamics are not visible on the monitor, but capnography gives you a lot of indication. So I think we have a very right person to tell about the basics of capnography in this class. So I give the mic back to you, Shirley, to take it forward so that we can start the class.
I invite Dr. Nivedita, my co-screen coordinator, to introduce the speaker and to commence this session.
Good evening, everyone. Myself, Dr. Nivedita, working as assistant professor in Narayana Medical College, Andhra Pradesh. Uh, this platform, which is ISA National Online PG class, is definitely beneficial to all the PG students and budding anesthetists. Apart from the theoretical knowledge they have, this will definitely help to enlighten their knowledge with all the valuable insights and practical points from the well experienced and eminent anesthetist. So I suggest all the PG students to utilize this opportunity. Now I would like to extend my special welcome to our distinguished faculty, Dr. Hedal Kumar Shah sir. Dr. Hetal Kumar Shah sir, who is working as senior consultant and cardiac anesthetist in NH Multispecialty Hospital, Ahmedabad. His areas of interest are high-risk surgeries, cardiac patient for non-cardiac surgery, airway, pediatric cardiac anesthesia, capnography, and lung protective strategies. With his remarkable work in this field, Sir was awarded with Dr. Cobb's Award, and he has got many achievements like prestigious Dr. Devi Shetty's Award for Outstanding Doctor, and Sir was also been one of the quiz masters for ISA online quiz. Sir has got already 7 publications on his name. I welcome you, sir.
Thank you, ma'am. Thank you, and good evening, all of you. So let's start my talk.
Yeah, please go ahead.
Let me share my screen. Is it visible?
Yeah, visible.
Visible.
Make it full screen.
Yeah, I'll put this. Okay.
Yeah, fine.
Okay. So good evening, one and all. I being in a online meeting, we really don't know who all are there and who all are not there. So my pranam to all the seniors and all the colleagues and best wishes to all junior fellows who are there. Today, this was in a very really short notice. This has come, and what I'll be trying is that non-invasive capnography. I'll be taking probably in a two sides. One is basics. So today we will learn only about the basics of capnography and a few scenarios probably if time permits, right? So I'll be speaking on non-invasive capnography. So why there is an additional need of monitoring
Hmm.
when we have a multiple monitors available, like ECG, non-invasive blood pressure, saturations, temperature monitoring. Why to add on one more monitoring? Also, what is the need for an additional monitoring? That's the first question when any new monitoring comes in vogue. I always ask myself that why it is a need for an additional monitoring. So let's understand the basics of oxygenation and ventilation, right? So what happens that when we normally when we inspire air from the atmosphere, and that air goes through the nasopharynx, oropharynx, from glottic trachea to the lungs. So similarly, when we anesthetize or induce any patient, we put either endotracheal tube or we ventilate through them tracheostomy. So again, we give oxygen or oxygen air mixture or oxygen nitrous mixture, whatever we use. So we give that, and then those things, those air, those gases will go through the trachea into the lungs, and it will go to the bronchioles and ultimately to the alveoli. Now, at the alveolar level, this oxygen, so alveoli gets the oxygen, and this oxygen will get diffused into the pulmonary capillaries, and these pulmonary capillaries will have hemoglobin. So this oxygen will bind with those hemoglobins, and it will cause oxygenation of the blood. That is what we call oxygenation of the blood, and that we measure through pulse oximetry. Now, from that, now this oxygen-rich blood will go into the circulation, and it will reach to the left side of the heart, and then it will go eventually into the circulation to entire body and to the cellular level. Now, at cellular level, as we all know, the metabolism is happening, and this metabolism, this oxygenated blood, oxygen will get dissociated, and that oxygen will be used in the cellular metabolism, and that is what we call is the aerobic metabolism at the cellular level, right? Now, byproduct of this metabolism is carbon dioxide and water. So the carbon dioxide will get generated at the as a side effect or as a byproduct of cellular aerobic cellular metabolism, and this carbon dioxide needs to get washed out, so it will go into the circulation, and through this circulation it will come to the lung, and at the pulmonary capillaries, which is very close to the alveoli, this CO2 will diffuse into the alveoli, and that CO2 will come out to the exhalation, right? So the entire process, from inspiration we take air oxygen, or under anesthesia oxygen air, oxygen nitrous, or only oxygen. That oxygen will bind with hemoglobin. That process is called oxygenation, and that oxygenated blood will go to the cellular level through the circulation, and that at cellular level aerobic metabolism happens. CO2 is produced as a byproduct of it, and that CO2 again through the circulation will go into the lung, and it will get expired. So this is the whole process which happens, right? And that oxygenation will this will come out to the ventilation, right? Carbon dioxide will come out of this thing. So what we have a basic monitoring: temperature, pulse oximetry, ECG, and uh, uh, NIBP, non-invasive blood pressure monitor. Out of that, pulse oximetry measures the oxygenation. So it will monitor only oxygenation. Now, so what about circulation? What about metabolism? And what about ventilation? So do we have any parameters to measure circulation, metabolism, and ventilation? Yeah, somebody can tell me that I can use NIBP to measure circulation. But as we all know that blood pressure is not whatever the blood pressure reading, it does not correlate with your cardiac output. So you may have a good cardiac output with 90 systolic pressure. You may have a bad cardiac output with 150 pressure also, right? So NIBP cannot be the surrogate marker of a circulation. So my blood pressure is good, that means my circulation is good. I mean, we cannot say definitely. Do we have any parameters to do the metabolism, right? So somebody can say that okay, we can monitor lactate, but again, that will be additional monitor. You need to probably have a ABG, or you probably will have to send some samples to know. But we don't have a real-time monitoring, so that will take. You can draw the blood, send to the labs, get the lactate level, but then probably things can change. And ventilation, like apart from ventilator machines, which gives you some idea about ventilation, we don't have any monitor. So how do we measure all of this? Do we have a single monitoring for all this? So answer is yes, we do have, and that is capnography. So capnography measures ventilation, perfusion, and metabolism. So it can give you idea of all these three. And oxygenation, you can definitely monitor through your pulse oximeter. So by monitoring this uh, capnography, you get a graphical waveform which is available for interpretation. Now, if you can identify this waveform, and if you can understand this waveform, you can actually diagnose the problem is at ventilation level, perfusion level, or at a metabolism level, or whether it is in the inspiratory area or whether it is in the expiratory area. So this graphical waveform can tell you a lot of things about what to intervene in patient, and that can bring a good outcome of the patient, right? So because of all this background, it becomes standard of care. And ASA close claim study, they were reviewing certain data, and what they found out that whenever there is a near arrest scenario which has happened, or there is a morbidity or mortality which has happened, which was not planned or which was not anticipated, right? Plan was the wrong word, but not anticipated. They have assessed those cases, and they found out that 34% of the damaging events involves the respiratory system under anesthesia, right? So out of 100 damaging events, almost one third of these events involves the respiratory system. And what they have found out and what they are proposing is that 93% all of these cases, 93%, almost 100% of these cases could have been prevented by monitoring with pulse oximetry, capnography, or both. So, had you used these tools, pulse oximetry and capnography, so you could have avoided almost all one third damaging events. And that's why ASA has included capnography in its standards for basic monitoring since long. However, ISA, Indian Society of Anesthesia, our own body, has also designated capnography as a mandatory standard for monitoring nowadays, right? So let's take a poll. You can type in a chat box and we'll see how the response is coming, right? So all of you can open your chat box and please answer this. How many of using capnography? I'll just give you 5 seconds. So Dr. Sarli, Dr. Divisa can. Okay, great. Good responses. I'm sorry. Do you really interpret? The second question is, if you are using capnography, do you really interpret and take actions on it? So you have used capnography and you got some waveform. So are you really interpreting and taking action on it? Either you are interpreting waveform or either you are interpreting number. And are you taking any response on it? 5 seconds to answer. Yes, no, maybe. Three answers can come. I think for the answers, I can see that a lot of people are using it and a lot of people are interpreting it also. Wow, that's great. So I think my job becomes easier. Okay. The third question. How many times do you reach to the conclusion as what is the problem? Whether the problem is at ventilation, whether the problem is at metabolism, whether the problem is at a circulation. So how many times could you reach to that answer? Another 5 seconds for you. Almost always, many times, most of the times. Beautiful. I think we have got a very learned audience, so my job will become much easier. Let's
Dr.
move
Hitel,
forward.
there will be a special prize also for today if they are answering very well.
Oh wow, what is that price? Or if you can
We will
announce
tell in
now.
the we will tell in the end. And you, in the meanwhile, you keep on teaching.
Okay, okay, fine. So my disclaimer, majority of images and photos are original. Certain situations are modified and may not be the real scenario, but motive of that is purely for educational purpose and not to show any technique or method is superior or inferior. This is not a sponsored lecture and I'm not marketing any product in this. So let's start from the basics, definitions. What is capnography? Capnography is a graphical display of CO2 concentration versus time, which is called time capnograph, or expired volume, which is a volume capnograph during a respirator cycle. So simplifying that, when you take a breathing, when you do the inspiration and expiration, whatever the graphical form you get is called capnography. And there are two things. One is a on x-axis you have a capno reading, uh, which will be numerical reading, and on y-axis you probably will have a time or expired volume. So depending on that, it becomes a time capnograph or it becomes a volume capnograph. And what is capnometry? The numerical display of this maximum inspiratory and expiratory carbon dioxide concentration during the respiratory cycle is called capnography. So whatever the number we see besides this graph is called capnometry. So capnography and capnometry. So there are two methods. All of us know there is a mainstream method and there is a side stream method. Mainstream method, you have the IR source or IR detector, which is detecting the carbon dioxide is inline or is in the circuit itself. So that becomes a mainstream. While in side stream, what we'll have is in the circuit, we have a sampling adapter, which will take some sample, and that sample will go to the IR detector, which is not into the circuit but away from it, and it will detect CO2 and it will display. So this becomes when the IR detector, which is detecting the detecting CO2, is in the circuit, in the ventilator circuit, it is called mainstream. When there is a sampling adapter and it takes the sample of expired or inspired air into the sensor, which is away, which is not inbuilt into the circuit, it is called side stream, right? Now, there are fewer advantages and disadvantages. Mainstream is obviously a good advantage because it is measuring inside, while side AM will have some sampling which is happening. So there could be a dilution or could be sampling error, a lot of things. But majority of the time we use side stream. The reason being the mainstream becomes very bulky. It has got a very heavier thing, while side stream are it just needs a sampling adapter into the circuit. So it is a very lightweight. So that's why the side stream is in prop more used. And mainstream being a bulky causes sometimes a lot of weight onto the circuit, and especially in a pediatric patients, this becomes a lot of bulkier, and there is a possibility of some mishaps can happen. But there are different advantages and disadvantages with both. Either of that, but we should use this. And finally, this IR detector detects carbon dioxide and it generates this kind of squarish waveform or inverted U wave or a squarish waveform, which you can say. And there are different phases. Now we will go. This is called time capnograph, right? So because there is a time on x-axis and here is the CO2 value. So this becomes a time capnograph. Majority of the machines display the time capnograph. So capnographic waveform, let's understand this waveform and let's see what are the phases of it, right? So capnograph detects only carbon dioxide from ventilation. It will not detect any other gas apart from carbon dioxide. It will not detect oxygen. It will not detect nitrous. It will not detect any other gases which is going to be there. So it will only detect only and only detect carbon dioxide from ventilation. So during inspiration, there is no CO2 present. So baseline is normally zero. So the first phase of capnograph is baseline, which is the beginning of exhalation, end of inspiration and beginning of exhalation is called phase one of capnogram, and it is baseline because end of inspiration and beginning of expiration will not have any air movement probably. There will be a pause. There will be no carbon dioxide detected during that time, and that is why this should be baseline, and this should be at baseline. This should be at zero level, right? So capnogram phase one is has to be at baseline. It has to be at a zero level, which is the end of inspiration and beginning of exhalation. Now, phase one. What will happen then? The patient will start expiring, right? So beginning of exhalation will start. Now, what will happen initially when you are exhaling from the first air which is coming from nose, mouth, nasopharynx or oropharynx, and this area doesn't have a gas exchange which is going to happen. So whatever the air or oxygen which has gone in is coming out. So obviously because there is no gas exchange is happening and inspire air in a normal breathing patient or uh, on a ventilated patients, we don't give all carbon dioxide to them, right? We give only oxygen, air, or nitrous oxide. So there will be no CO2 present. So what will happen is that this air from trachea, posterior pharynx, mouth and nose, where there is no gas exchange is happening, so there will be no CO2 present, and this is called anatomical dead space. Why it is a dead space? Because this space, whatever the air or oxygen was there, has not contributed anything into the patient's body. So that is why it is called a dead space. The way it has gone, the way it has come out, right? So this is called anatomical dead space. And this becomes the phase one. So ventilated areas which do not participate in gas exchange is called dead space. So total dead space would be anatomical dead space, as I mentioned, trachea, pharynx, oropharynx, nasopharynx, nose, mouth. So this becomes anatomical dead space. There are certain alveolar dead space. Now, how the alveolar dead space can happen? Because alveoli is always exchanging, but there are certain alveoli which are getting ventilated, but it doesn't have a blood flow there. So the pulmonary capillaries are not having either those capillaries are closed, or it could be there will be spasm, so there is no blood flow which is happening. So these alveoli are getting gases, but it is not participating into the exchange, right? So this is called alveolar dead space. So total dead space becomes the anatomical plus alveolar dead space, right? This is one question now. So since Bajaj sir has said that you will get some this thing, some winners will you will get some reward. So I'll start. I thought why not to put some question. So the first question: is there any dead space? Do you think? 10 seconds for this. Any other dead space? Do you think we have anatomical dead space and alveolar dead space? Do you think any other dead space could be possibility? If yes, what is the answer? Sital, iPhone. Great, lot of answers are coming. 10 seconds over. So yes, there could be one more dead space, which is mechanical dead space, especially patients under anesthesia. Your circuits is also making a part of dead space because they will contain some air or oxygen, but it is not participating into gas exchange. So artificial airways like ventilator circuits, extension boards, and extensions, your probably filters, these are also adding to the mechanical dead space. Now, why we need to understand that this mechanical dead space is very, very important. This becomes a very important part in pediatric patients because this will add to the dead space ventilation, and this will lead to probably uh, less gas exchange because the volumes are less and they will also cover some volume. So this is very important in pediatric patients, right? I hope everybody is clear about this dead space part. Okay. Now the second waveform which is going to come is called the ascending phase of capnogram. This ascending phase is part of early exhalation, right? So now the gases which is get exchanged. Now the CO2 is present in this gas and it is slowly coming out and start getting detected at a IR level or from capnometers, and this will lead to this ascending limb of capnogram, which is the second phase. So what happens? So now the air which is from the alveoli which has participated into gas exchange, and now it is filled with carbon dioxide. Now those air after this dead space air which is gone, this air will start coming, and this will have a CO2, and this will cause this ascending phase of capnogram. So the CO2 from the alveoli begins to reach to the upper airway and mix with the dead space air, and since it is causing mixing of the carbon dioxide start detecting, it causes a rapid rise in the amount of CO2 which is getting detected at the capnometer, and that's why you have a ascending limb. So the air, uh, the carbon dioxide which is there in the alveoli is coming out, and that is causing now sudden, because the dead space air has no carbon dioxide. Now suddenly carbon dioxide has come. That is why it is causing this ascending limb of uh, capnogram, and this is phase two. This is happening because of the air. Now, carbon dioxide is getting detected at the IR level, right? Now, then the third phase which is coming, which is called alveolar plateau phase. Now you will see a third waveform which is slightly horizontal, but slightly not exactly horizontal, but slightly ascending kind of thing, but very small ascending kind of waveform which is going to come, which is sort of in a plateau phase. Why this is going to form now? Let us understand. Now what will happen? The all the alveoli which is participating into the gas exchange, and all the alveoli which is having a CO2 uniform concentration of the CO2 is now that air or that carbon dioxide reached air is now getting detected at the IR level. So CO2 rich alveolar gas now constitutes the majority of the exhaled air. And since all the alveoli will have the PCO2 or the CO2 concentration same, so that's how you will get a plateau phase, right? So because the uniform concentration of the CO2 from alveoli to the mouth, so you'll get a plateau phase. Now the CO2 is not going to be higher. Then why this is a slightly ascending? It is not a flat, not like a 0 degree, but it will be hardly about 2, 3, 4, 5 degree slanting kind of phase which will happen. So there are a concept of a slow alveoli and fast alveoli. So there are certain alveoli which is getting emptied faster, and there are certain alveoli which is emptied very slowly. So this, because of the slow and fast alveoli difference, there are some initially the fast alveoli get empty, but the slow alveoli will start getting emptying slowly. So that is why there is a little variation which can happen, and that is producing a slightly upslope into this sort of a plateau phase. And the end of expiration happens and the beginning of inspiration starts. Now, this point, which is ending the expiration, is called end tidal, and this happens at the end of wave of the exhalation or expiration. Now, this point is the numerical display at this whatever the level of CO2 which comes into the waveform. This point CO2 will be displayed as a numerical value, and this becomes your end tidal CO2, right? So the end tidal CO2, the number which we see is coming from this point where there is an end of exhalation and beginning of inhalation, inspiration starts. So that is the point. Whatever the value which is there will be displayed as a numerical, and that becomes an end tidal CO2, right? So capnograph phase 3 is end of exhalation, contains the highest concentration of the CO2, and this is the number which you can see on your monitor. Normal ET CO2 is 30 to 35 millimeter of Hg. That's the normal value. Now, exhalation has ended. Now, the beginning of inspiration starts. Now, inspired air, whether we are air, we are taking air, whether we are taking oxygen, oxygen air, or oxygen nitrous combination, will not have any CO2. And as we know, this IR detects only CO2. So that's why there will be a rapid drop into the CO2 level. So that's why this descending phase of inspiration starts, and this inspiratory downstroke returns to baseline. So this indicates the inspiration, right? So the phase 4 descending phase, now the inspiration starts and inspiratory air doesn't have any carbon dioxide. So carbon dioxide level quickly drops to zero. And when you saw the ascending phase, now you will see the descending phase in inspiration, right? So, as I told you, end-tidal CO2 reflects changes in metabolism at tissue level, circulation of blood, and ventilation, which is the movement of air in and out of the lungs. How it happens? So, if the metabolism is higher, the CO2 production will be higher, and if that high CO2 production, you will have a high EtCO2. If your circulation is higher or if your circulation is sluggish, let's say in the opposite direction, if your circulation is having a low or patient is having a low cardiac output, the the blood which is going to reach at the tissue level will be less, but the CO2 production will be higher. but the blood is not reaching. So the blood which is coming back to the lung will have a low CO2 and that will produce a low EtCO2. So that can tell you about the that circulation is poor, right? And pardon? One second. Okay. So, and ventilation. So, whether your tube is in situ or tube has displayed, so all these things can tell you about, can reflect changes in EtCO2 and you can diagnose it. So, let's say in metabolism, if there is a increased muscular activity like shivering, which is going to happen with the in the OR, or if there is a malignant hyperthermia that will produce a lot of carbon dioxide and that will cause an increase in EtCO2. Or you can have a different that if you give a muscle relaxation to some patient, so muscle activity will go down, will CO2 production will go down. Or in case of hypothermia, CO2 production will go down. That will cause a decrease in EtCO2. On circulation, if you have a cardiac output which is increased during resuscitation or bicarb infusion was given, or suddenly tourniquet is released and then blood has come gushed into the body and suddenly improve the circulation, will cause increase in EtCO2. Or if you have a decreased cardiac output, or if you have a pulmonary embolism kind of scenario, will produce decrease in EtCO2. So this is metabolism and this is circulation. On ventilation, let's say if your patient is having a bronchospasm and you have given some drugs and the bronchospasm has relieved, will cause increase in EtCO2. Or if there is a decreased manual ventilation, which will also increase in EtCO2.
Hello.
Or if, hello,
Hani Manish ji.
yeah.
See,
Or if you have a bronchospasm kind of scenario, or if you have increased minute ventilation, have you changed the ventilation of this patient, will produce a decrease in EtCO2. So all this ventilation for the fusion and metabolism can reflect in EtCO2. Another question, how would your capnograph change if you intentionally decrease your respiratory rate? I'm sorry, increase your respiratory rate to 20. I'm sorry, this is not decreased, it is increased. How would your capnograph change if you intentionally increase your respiratory rate to 20? So normal respiratory rate is 12 to 14. If you increase your respiratory rate to 20, not decrease, sorry for typo error, what will happen to frequency? What will happen to duration? What will happen to height? And what will happen to shape? So this is a normal capnograph. And if you increase your respiratory rate, what will happen? Your EtCO2 will change definitely, and EtCO2 will go down because now you are hyperventilating that patient. So what will happen to the frequency? Frequency will increase. Duration will go down because the ventilation time will go down. The height will reduce because the EtCO2 will drop, but the shape remains normal, right? Similarly, what will happen to the capnograph if you intentionally decrease your respiratory rate to 8? What will happen to frequency, duration, height, and shape? This is a normal capnograph. If you decrease your respiratory rate, your EtCO2 will go up and your frequency will go down, your duration will increase because now you have in 1 minute you are doing only 8 cycles. Height will improve because the EtCO2 will go up, but the shape remains normal, right? So from that also you can detect, right? So you get a normal capnogram like this. In hyperventilation, you can get waveform like this. In hypoventilation, you can get waveform like this. Always we have to protect the tube under anesthesia. That's the uh, role of an anesthesiologist. So you can confirm your ET tube placement by EtCO2. So once you intubate that patient, sometimes you have a difficult patient like this, and you are not sure whether your tube has gone into the trachea or esophagus. You connect to the EtCO2 and you can identify that your ventilation is happening, your tube is in a correct position. Or sometimes it may happen that your tube gets displaced, especially in a pediatric patients, when you have put the uncuffed tube, sometimes, and if it is not gone properly in or not properly fixed. Sometimes, or with the positioning change of the positioning, sometimes it gets displaced and goes into the esophagus, can be diagnosed with the ETCO2. So you get a suddenly squarish waveform and then you start getting no waveform or a very slow waveform. So that will tell you that the tube has displaced, right? And that is why it is now mandatory that your intubation has to be documented with ETCO2 or confirmed with the ETCO2. And that's how that's very, very important to have a ETCO2 monitoring. As we all know, in CPR, capnography is very, very important. So how do we know that capnography can tell us about the CPR? So CPR and ETCO2. So ETCO2 can be used as a feedback to know the depth, rate, and force of chest compressions during CPR. So whether you are doing effective compressions or not can be detected with the ETCO2, right? And what will happen that in the when you have a return of spontaneous circulation, this ETCO2 can detect effective when if you are giving effective CPR and if you get a return of spontaneous circulation, there will be sudden spike in ETCO2, and that will tell you that your return of spontaneous circulation, the aim of CPR has achieved. You can stop CPR and check for the rhythm when you see this kind of spike into your during resuscitation in ETCO2. So there is a beautiful article which says that if you are doing a CPR and if your average ETCO2 is between 4 to 10, those patients are likely not to survive. But if your average ETCO2 during compression is roughly around 30, these patients are likely to survive and they will get discharged in a normal conditions at home. So ETCO2 numbers or ETCO2 monitoring will tell you about your effective compressions. Now, can we have a quick test? So my basic talk is over. With the permission of the moderators, can we start MCQs?
Yes, sir.
Yeah. So how
We
per
proceed.
question we will give how much time to them
So 45 seconds.
for per question, right?
Yeah.
Sure. So the first question, and there are five questions. Uh, please give correct answer because that will tell me that I have done my job well. Anyway, uh, the first question is when alveolar CO2 levels fall, when alveolar CO2 levels falls, what happens to the carbon dioxide levels in the blood leaving the lungs? Okay, when alveolar CO2 levels falls, what happens to the carbon dioxide levels in the blood leaving the lung? Increase, decrease, remain high, or no change? The time starts now. Please let me know at 45 seconds, please.
Dr. Kanu Taral has answered first, sir. Correct answer.
Wow. Great. Can I go to second question? 45 seconds over.
Yes, sir.
Okay. Next question. The part of this picture reflects which waveform or which air? It is a dead space air which forms this part of the graph. Is it the mixed air? Is it the inhalation or is it the alveolar air? Your time starts
Dr.
now.
Rajesh has answered the first.
Oh wow, great. So are we getting answers from all or only few are participating?
Many are giving the answers, sir.
Great. Want 100% participate.
Done, sir. Time is up.
Yeah. Third question. What changes of the ETCO2 value would indicate a return of spontaneous circulation? What change of the ETCO2 value would indicate a return of spontaneous circulation? A sudden decrease in the value, a sudden increase in the value, any value greater than 20 mm of Hg, or ETCO2 values will not indicate a return of spontaneous circulation. The time starts now.
Dr. Saida has given the first correct answers.
Wow, great. Congratulations. मुझे लगता है मैं केबीसी खिला रहा हूँ फास्टेस्ट फिंगर फर्स्ट. चलो अमित आपके स्टाइल में कुछ करो. इस टाइम हो
Yes, sir.
और आपका समय हुआ है समाप्त. अगला क्वेश्चन हमारे पार्टिसिपेंट्स के लिए ये था आपके स्क्रीन के ऊपर. केबीसी स्टाइल.
Hmm.
You have induced and intubated the patient. You are ventilating at approximately 40 breaths per minute with an appropriate tidal volume. The ETCO2 monitor shows a normally shaped waveform with a value of 22 mm/G. What would you do? I repeat the question. You have induced and intubated the patient. You are ventilating at approximately 14 breaths per minute with an appropriate tidal volume. The ETCO2 monitor shows a normally shaped waveform with a value of 22 mm/G. What would you do? You would increase the respiratory rate. You would decrease the respiratory rate. Keep the rate the same but increase the tidal volume, or you keep ventilating at the same rate and depth. और आपके 45 सेकंड शुरू होते हैं अब.
Many has answered the correct answers, sir. That is B.
Wow, that's great.
Done, sir.
या आपका समय होता है समाप्त. कंप्यूटर बाबा अगला क्वेश्चन देंगे अभी अपने को और ये लास्ट क्वेश्चन है. व्हाट इज नॉर्मल रेंज ऑफ EtCO2? आपके ऑप्शंस है 25 से 30, 30 से 35, 35 से 40 या 40 से 45, 40 टू 45. आपका समय शुरू होता है.
What is the response, Dr. Nivedita?
Many has answered correctly, ma'am. Uh, Dr. Chirag has answered it correctly first, ma'am.
Done.
Yes, ma'am.
Done,
Okay,
sir.
Dr. Chirag. Done. Thanks a lot. Thank you very much. Thank you. We'll be taking case scenarios in probably some next time when the ISA platform allows me. Thank you. That's all from my side. Thank you all. I'm happy to take any questions or if anyone has any.
Dr. Nivedita, just check if there are any questions in the chat box.
Yes, ma'am. As of now, there are no questions to be addressed, ma'am.
Anybody wants to ask questions, they can please type in the chat box.
Shirley, have you recorded the person who
Yes,
has
sir.
answered the most correct
Yes, sir.
answer and first?
Yes, sir. The thing is that Dr. Divya Vadivel has answered twice first, sir.
Okay, great. So that means just write down in the chat box asking for the name, designation, email also. So we will be
Yes, sir.
sending the certificates to the winner. So there are many questions coming. Nivedita and Shirley, be careful. We have
Uh,
to take all the
there is a
questions.
query
Yes,
from
sir.
Hina Madam, sir.
Hmm. Ina madam to can ask directly also. Why she has to write there in the chat box?
Which
Yeah.
are other areas for use of ETCO2 apart from OT, sir?
Yeah. Dr. Ital,
Good question. प्रोफेसर
answer.
प्रोफेसर एचओडी होते हैं डिफिकल्ट क्वेश्चन no no so as of now all of us when we talk about DTC we talk about only OT scenario or anesthesia scenario but there are other areas especially endoscopy CT scan where we give a conscious sedation or a moderate sedation to the patient so these are the areas where we can use non-invasive ETCO2 we can use in case of emergency. Uh, role of VTCO2 in emergency is very scarce and they don't probably use it at full potential. In emergency scenario, when you get a patient who is you don't know, probably will have very few history. You are seeing the patient for the first time if you apply ETCO2 monitoring there and probably get some idea, probably in the next talk when I will be discussing certain clinical scenarios where you can identify from ETCO2 how can you reach to the diagnosis. So that can also be useful in case of that can be an extended use of ETCO2 monitoring as we are not using it nicely. This is my view. I hope I
Dr.
have
Hital,
answered.
So,
Yes,
Dr. Hital,
yes, sir.
people are asking about the right answers and the logic behind the answering, clinical reasoning. I think we should be.
Ah, okay. Shall I share my PPT again and
You can do. You can give the answers and the logical reasoning about behind every answer.
so let's start with last question. What is the normal range of ETCO? It is 30 to 35. I mean, which I have already described in my talk. This is the question. Question number four. You have induced and intubated the patient. You are ventilating at 14 breaths per minute with an appropriate tidal volume. The ETCO to monitor shows a normally shaped waveform with a value of 22 mFIG. So that means your probably minute ventilation is higher and you are not achieving the Normal ET should be in 30 to 35 range, and it is slightly lower. So probably you are hyperventilating this patient. So you have to either cut down your respiratory rate or you have to cut down your tidal volume to make it physiological for that patient. So you cannot
So,
increase the
Dr.
respiratory
Hital,
rate.
Dr.
Yes,
Hital,
yes.
in this question, I
Hmm,
think the
hmm,
most clinical tricky part is we are
hmm.
already giving 14 breaths per minute. And
Yes.
I think decreasing the tidal volume will be more important here rather than just decreasing the respiratory rate, the breath rate.
Yes. Perfect. I agree to that point. Uh, but I mean that's not the option. So we can also reduce the respiratory rate and I mean because that's the only option which we have. Right? So you cannot increase the tidal volume, which is the third option. You cannot keep ventilating at the same rate and depth, and you cannot increase obviously the respiratory rate. So the options which are available will have a decrease the respiratory rate, but you can either reduce your respiratory rate or, as sir has mentioned, you can reduce your tidal volume and keep the rate same. So in any way, you have to play with your minute volume. So whatever the minute volume which you are giving to the patient needs to come down, right? So that's the basic funda of this answer. So so you are hyperventilating this patient and you need to cut down the hyperventilation. That's the motto of this question. Let's come to the third question. Okay. What change of the ETCO2 value would indicate a return of spontaneous circulation? So as we saw, a sudden increase in the value is important. Uh, Obviously, decrease in the value is a deteriorating sign of circulation. Any value greater than 20 will tell you that your compressions are effective, definitely, and possibly this patient will have a chance of survival. Obviously, this D option is out of the question. So, a sudden increase in the value of ETCO2. So, let's say if you're compressing in when you're getting a ETCO2 of 20, and suddenly you see the sudden spike, and your ETCO2 value goes to 40, 42. That means the patient has achieved a return of spontaneous circulation. So, sudden increase in the value is the right answer in this. The part of the picture reflects, obviously, I mean, we have discussed at length. This is the alveolar gas because this is a plateau which we are seeing, right? Alveolar plateau waveform, and this is the alveolar air uh, which is making this waveform. Obviously, dead space air will not have carbon dioxide, so it should be at the baseline. Mixed air will give you up upstick. Inhalation will not have a CO2, so it will go down slope. And this is a plateau phase, so this is the alveolar gas which is making this waveform. And when alveolar CO2 levels falls, what happens to the CO2 levels in the blood leaving the lungs? So obviously, any blood which is leaving the lung will have a low CO2 value. So we are basically, this is a basic lecture, so I have not taken any pathological scenarios in this. This is only physiological which we are talking right now. So I'm considering everything is good, lung is good, the circulation is good, and this is what on that basis. So alveolar CO2 level falls. Anyway, whenever any blood which is leaving the lung will have a low CO2 level because the CO2 which has diffused from blood into the alveolar. So if the alveolar CO2 levels falls, that means the blood which is leaving the lung will have a low CO2 or entering into the lung will have a low CO2. That is why your alveolar CO2 level is less, right? So the CO2 production is less, so CO2 level is less. So alveolar CO2 level falls. What happens to the CO2 levels in the blood leaving the lung will be having a low CO2. So this is the decrease is the correct answer. This remaining, remember this is a physiology. Now we are considering the patient as normal. We are not taking into any pathological scenario as of now. This can either of the answers can come, but depending on the pathology or the clinical scenario. But as of now, we are basic. This is a basic lecture, so we have taken only physiology into this. So the decrease is the right answer. I hope I've done the justice.
Can we take more questions, sir?
Yeah, please.
Uh, Normal range of ETCO2 for neurosurgery. One of the questions is about normal range of ETCO2 for neurosurgery.
As you all know, change in CO2 will lead to the change in circulation of the cerebrum, right? So cerebral circulation is very critical with the CO2 level. So initial concept was that when you are operating on a neurosurgery, you will have to have a less cerebral blood flow. So the thing is that ICP is equal to it is the difference of uh, the cerebral blood flow which is coming, and if you can maintain your cerebral blood flow little lower, so the ICP can be lower. But that concept has gone, and most of the time now it is required that you have to maintain a normal CO2. Yeah, in certain scenarios, probably will have to induce the vasospasm or vasodilatation. Then probably you can change your CO2 levels. But otherwise, the newer concept says that you should have a normoventilation, normocapnia kind of thing. So you can keep a normal EtCO2 in majority of the neurosurgeries. The previous concept of keeping or hyperventilating and keeping low CO2 is now no more applicable.
So the next question is about the significance of angles in capnogram.
Yeah, that's a nice question. I have not purposefully taken. So there are two angles which is coming when the inspiratory limb and the plateau which is coming, there becomes one angle, and there is a second angle which will become the end of exhalation and beginning of inspiration. So there are two angles which is coming. Now, depending on that angle, you can actually diagnose the condition, that any pathological condition which is going to happen, which is happening or not. But I mean, we can definitely once we will go into the clinical scenarios, probably you can come to know from the if you go to graphs also. So those angles, the change of those angles will tell you about the pathological conditions.
Can we have mobile EtCO2?
Yeah, I think there are it is sort of which is coming like a pulsars which we have got mobile pulsars. I think there are few companies which have come up with the mobile ETCO2 also. So you don't need, I mean, you just have to take like a smaller pulsars kind of thing, and you attach to this thing, and you can get the display over there only on the screen. So mobile ETCO2 is available. Yes, it is available. Very
So
much
I
available.
will just add one more thing here. There are many PGs, academicians attending this webinar. So if somebody really wants to get a more innovative, a new, mobile and portable ETCO2, they want to develop, I think we can go ahead with that innovation cell of ISA. So they can prepare a draft proposal. They can submit to the secretary's national headquarters email, and if it's found suitable, so we can go ahead with the this one manufacturing of this portable ETCO2. If it's very cheap, because that can be supplied to the every part of the country in a very subsidized rates. The cost will be less. So if that can be made, so it will be made available to every anesthesiologist in the country. You can always carry it in your handbag or something like that. So we really invite proposals from every part of the country for this portable mobile ETCO2.
Next question, sir. How to correlate ABG reports, capnogram with EBG reports?
Yeah. So I purposefully skipped that. Anyway, there is a difference. As we know, ABG will indicate the CO2 level in the blood. So that will be at the arterial levels, right? So when we draw the blood from the artery, which is at the near to the, let's say it's a tissue level carbon dioxide. Now that blood will come into the lung, and there will be diffusion of carbon dioxide which is going into the alveoli, and that will come as a EtCO2. So there is, and this diffusion will happen on a concentration basis. So wherever there is a higher concentration, wherever there is a lower concentration. So the from higher concentration to the lower concentration, the gas will move. So the blood which is coming into the lung will have a higher concentration, and the alveoli will have a bit of lower concentration. So what they say is that there has to be a difference of 5 between the arterial carbon dioxide and the end-tidal CO2. So normal difference is 5. Whenever there is a wide difference, so you see your EtCO2, let's say about 35. So you expect your PCO2, PaCO2 or arterial CO2 should be around 40. Let's say if you're drawn a ABG and you are seeing your CO2 60, that means there is some problem which is going. So the normal difference between the arterial and end-tidal CO2 is 5. Anything above than that is pathological.
And one more thing to add here, Dr. Hitar, because
Yeah,
when
sir.
we take the ABG sample, there should not be a delay between the interpretation of the ABG as well as the ETC2s as a that particular point of time, whatever the level or value of the ETCO2. And I think the reports coming after 10 minutes, entire physiology and metabolism also changes during those 10 minutes. So that is very, very important correlation.
So this normally happens. So let's say in a normal scenario, what happens when you induce the patient, you put a arterial line and you induce the patient, and immediately you draw a sample for the ABG, and then when actually ventilation effect starts, and what will happen? Your ETC2 will go down. So whenever you are drawing, what a good point which Maria sir has pointed out, whenever you are drawing a ABG sample, you note down your ETC2 at that point of time. Because if you have a delay of 2 or 3 minutes also in getting the report, your ETCO2 value might change. You should be knowing that. That's a good point, Subhash.
Next question. Can we diagnose bronchospasm from ETCO2? And what else can it help?
Yes, definitely we can diagnose bronchospasm. As I told you, there are different waveforms which is formed from different movement of respiration. So you can definitely diagnose bronchospasm. How? I'm not taking it now because it is coming in a pathological scenario. And one more thing, what I have also mentioned in my lecture, if you have noticed, that if you, whenever there is a patient of bronchospasm, let's say acute exacerbation of COPD or acute asthmatic attack patient has come to you, you will give some treatment to that. Now, you cannot every time start keep on oscillating. But if you have ETCO2, from ETCO2, you can diagnose that your effectiveness of treatment is also you can identify. So yes, definitely in a bronchospasm scenario, it is a very useful tool.
Cardiac output monitoring based on ETCO2.
It's a nice concept, and there are few companies who has come up with this monitoring devices. It's probably I would say it's a very primitive stage as of now because we need a lot of studies which can tell you that this cardiac output on base of EtCO2 should be validating against the standard cardiac output monitoring devices. But it's a beautiful concept. In fact, there is one more idea which I have is that you can diagnose early hypotension also in this in patients uh, from EtCO2. So that also can be taken up. So that's EtCO2 has a beautiful things there, and you can diagnose a lot many things. Yeah, it is there in the market. It is sort of based cardiac output, but yeah, it needs still validation of time.
Can you show us some abnormal waveforms?
This is the
Yeah,
next class. Next class.
Next class. Okay. Moving on to the next question. If patient is hypothermic and EtCO2 is 22, should be done.
treat the cause.
Next, permissible level of EtCO2 during radio-assisted thoracoscopic surgery using EtCO2, using carbon dioxide.
Until it is not causing any hemodynamic changes to your patient. So it will be variable from it has to be individualistic. So each patient can behave abnormally. So till it doesn't cause any problem in your patient's hemodynamics, that should be the range. There is no fixed answer to it.
Okay, sir. Can
Next
we
question.
diagnose?
What is the role of EtCO2 in one lung ventilation?
Absolutely. When you do a one lung ventilation, there could be two or three scenarios. Uh, One, it is a lung surgery where you do a one lung ventilation, and obviously you have a pathologic lung and physiologic normal lung, right? So, and when you're operating on a pathologic lung, you are ventilating with a physiologic lung, right? So you need to see that this physiological lung will not have any issue, right? Because now that is the only lung which is contributing to the oxygen and carbon dioxide of the patient, maintaining the level, right? So maintaining or monitoring the EtCO2 rather than the number, the waveform is very important in lung ventilation.
Next
And
question, what is the use of volume capnography and why it is
Wow.
not used commonly?
Yeah, because it is not used commonly because most of the time the monitoring which we use or it is your monitoring which we use is not linked with the ventilator, right? The volume based capnograph has to be incorporated into the ventilator itself. Then only it will come because every time every patient will use different cardio volume, right? So that is why it is not uh, in use and it is not available because the ETC to manufacturing company is different, the ventilator manufacturing company is different, and it is not inbuilt. So that's why it is not much of use into the practice.
Next
next
question
question.
is causes of sudden rise in ETC immediately post creation of pneumoperitoneum in lap surgeries.
Post creation of yeah,
Pneumoperitoneum in
because the
laparoscopic surgery.
CO2 which is you are inflating CO2 into the body, this CO2 will start getting absorbed into the blood. So that there is a higher load of CO2 which is coming to the lung, and that's why the CO2 is you can see the rising with the CO2. I think I understood the question that when you are creating a pneumoperitoneum, you see the sudden rise in CO2, right?
Yes, sir.
Yeah, yeah. Very catastrophic condition would be the direct injection of CO2 into the blood. But that will have a very small time of rise in ET0, but then there will be sudden drop in ET0 which will happen because of the circulation which is going to get hampered.
Other question is on is mainstream ETCO2 more accurate?
Yes, yes. Mainstream ET0 is more accurate because it will avoid that sampling delay time and anything which is going to have an error with the sampling, we can avoid that. Yes, it is there, but not used because it becomes a little bit bulkier to the circuit. That's why it is not much preferred. But yes, it is more accurate than the side spin. Yes.
Any question left?
Yes, sir. Almost over, sir.
Almost over.
Yes, sir.
I think that's a very good class. All the questions, all the
Thank you.
bullets fired, they were given very good answers also. And I think that the basic part is clear. We will be moving to the this one advanced part with the different case scenarios in a while, not next week, but maybe after that. So that
Sure.
is one of the best class again for this year, starting with the capnography. And I think we will be moving towards. I think examinations are also around the corner at certain places.
Yes.
Yes, sir. Practical exam also in the Gujarat it is started from 21st
The first.
January up to the February 8th.
Okay, great. So that means we are having this very good class, so you can
Yes,
go
sir.
about it.
Yeah.
So just wait.
Very well explained, Itul sir. Congrats.
Thank you, ma'am. It is good is my at heart.
Yeah.
So it's time for us also to now felicitate our faculty and the people who are involved into this. My screen is visible.
Yes, sir.
Yes.
Visible.
So Dr. Hital, many thanks for taking this class and explaining it beautifully and in a very simple manner and taking up all the queries, doubts. I think almost everybody has cleared their doubts today on the basics of capnography. So thank you for being such a good faculty in this class, and we are really obliged to you.
Naini sir, I am thankful to you and I am obliged that I have joined this platform. And I am especially want to mention name of Dr. Subodh, whom you approached first and then he passed the baton to me.
No, he will be
And
coming in the
thanks
next
IS.
class. He is coming
Yeah,
in the next class with the ventilation modes. We are having the ventilation modes in the next class.
great.
Uh, Then Shirley, yourself did a wonderful job as a class screen coordinator. So thank you to you also.
Thank you, sir.
And so similarly, Nivedita, you also did a wonderful job. So you people are taking, something new into the anchoring. That was very impressive. So
Thank you,
thank
sir.
you to both of you. And Shirley, you gave the name, na? This person, we will just send me the name, details. I will be
Sure,
sending the
sir.
certificate to the email of the person concerned who answered the best
Yes, sir.
question. Yeah.
Yes, sir.
So
Yes, sir.
we will be
I
felicitating that.
want to thank Surly, Dr. Surly and Dr. Nivedita because I kept them a lot of busy in the chat box. Thanks for doing good job. Thank you.
Thank you, sir.
Thank you.
Thank you so much. It's a privilege.
Yeah, it's always good that the young people are there doing, anchoring the thing, and our veterans are also there. Dr. Madhuri is there, Dr. Ridhima, they both are the another class coordinators. So they train the people very well, and technically the class goes very well. And these classes become a permanent part of the ISA for teaching for the long time. I don't allow the recording in the beginning because that creates a little bit problem. So you can always go with the YouTube at ISA NHQ. You can always watch the recording of these classes. The recording should be uniform rather than if you allow somebody to record, then the things get a little bit of disturbed in the YouTube streaming. So we don't allow the recording in that. So, but it's available. You can download and you can record it from YouTube also the class if you want. That's another thing. So, anything else? Anybody wants to suggest something? Yeah, madam, Dr. Madhuri, madam. अरे अनम्यूट करो आपका वीडियो नहीं आ रहा.
Sir, you really explained very well the basics of capnometry. So, capnometry
Thank you so
actually
much.
in the OT and in the ICU are two different things. And in the exams, capnometry always is one thing which is asked by the examiners for table viva.
Yes.
And most of the situations that most common scenarios asked are embolism, bronchospasm, detachment of the tube disconnections, esophageal intubation. And one more thing, sir, I don't know whether you told, I was not listening, but there's one very simple question we often ask is the curar cleft. Very
These
simple,
are
like
part of these are
very
part of my
simple to
exam
diagnose.
talk.
Yeah, yeah, yeah. It is for next week or what, like mechanical ventilation?
Next to next mechanical
Any, no, it is
ventilation
very
is
simple. Ki
mechanical
when the
ventilation
patient
is
is,
next week.
no, no, but this is even in the OT when the patient is on the, when we are
Yeah.
ventilating
So
and,
all these scenarios which you have mentioned, ma'am, I have a
uh-huh,
live recording of those cases, and
okay,
I have about 15 to 20 cases which I have generated in my OR.
yeah,
And but then the adding all to this together will become a lot of long, lengthy
yes,
session.
yes.
So that's
No, no,
why
I was just telling
on
that we often ask that question on curar
yes.
cleft because it is very easy to diagnose for the students and they inevitably come out with the answer for curar cleft.
In fact, I have a solution that from curare cleft you can diagnose that the patient is early out of relaxation or late out of relaxation. So I
Yes,
have a lot of things. You can
yes,
uh,
yes.
The
if you
advanced
monitor
mode
it,
you will be.
yeah. So
It's
if you
very
monitor
easy
it,
to, huh,
yeah, I mean the strain of four
yeah,
uh, different scenarios. So all those are there.
yes.
Sir, there is one last query which is
Very
I
simple
can
question, very
answer.
simple. Soda bicarb, you say the metabolism, the CO2 is emitted, it will rise for a transient period. It's not that much. How much soda bicarb you give? Maximum you give with the 1 milliequivalent per kg body weight. I think that much CO2 load is not that much, I think. And that also we give in during the, some acidotic periods. And definitely you are going for the hyperventilation and those things. So I don't think so there is any other problem with that loading of the soda bicarb. Is it right, Dr. Hital?
Yes, yes, yes.
Uh, any other suggestion or comment or something to be given before we part off from the class?
This is Dr. Neeta here.
Yeah,
Uh,
Neeta madam. Good evening.
yes. I think the diagrams with which Hetal has explained, it gives a very good visual effect, and it will stay in the mind of the PGs for a very long time. And I think that is the thing which will help them in the exams. So kudos to you, Dr. Hetal, for the very beautifully represented diagrams.
Thank you so much, Nidha.
So
Thank you.
Dr. Hital winning the accolades in the national classes, and these will be remaining there on the YouTube, and anybody can watch them anytime, whenever you get time. I think for everyone, it's for everyone, for practitioners also. It's a good class. You can always go through them.
Yes.
As a teaching methodology, I think the ISA platform is also aiming side by side the quality improvement in the teaching methodology of the classes. I think by the end of the year, the entirely methodology will be changed altogether. The new format where everybody should be able to grasp whatever is being taught in the class. Any other, or we shall say goodbye?
Yeah, keeping a quiz was a very good solution to keep everybody awake. I'm Dr. Sailaja from
मैडम आपकी आवाज
Hyderabad.
सुन के ना वैसे ही पहचान हो जाती है कौन बोल रहा है.
नहीं सर, आप ही को पहचान, सर सब लोग नहीं पहचानते मुझे.
मैडम वीडियो दिखाओगे सबको आ जाएगा, वीडियो आएगा तो सब पहचान.
Yeah, good evening, and I'm happy to be attending this basic class of capnography, and so well presented by Hetal sir. મને બી ગુજરાતી આવડે છે, though I'm from Hyderabad.
બહુ સરસ ગુજરાતી આવડે છે.
આવડે છે, હા. And the quiz actually, I mean, I could see so much of participation, very well conducted, and looking forward to your next talk also. I mean, whenever it is being done, I'll definitely try to attend that.
Sure,
The
ma'am.
scenario based
My
one.
pleasure. Entirely my pleasure, ma'am. Thank you.
Thanks.
So that's for today. So we'll meet
Yes.
next week on Monday with the mechanical ventilation. Dr. Pawan Patak want to say something before.
Hello,
Let's listen from him.
sir.
Yes, sir.
If ISA has made it compulsory for monitoring aid during surgery, so it should be made compulsory for all laparoscopic procedure. All the laparoscopic
Sir, see,
procedure, it should be made compulsory, no?
sir, there are two
So
options.
usually we don't get that facility because the monitoring
Sir, there are two things.
procedures are not available everywhere.
Sir, two things. We have just
When
formed the guidelines that to guide everyone, but to
Yes.
enforce the guideline is not an easy step. It basically for every clinician, the guidelines are formed that this is the best way to go forward. It's an
Yes.
individual responsibility, it's an institutional responsibility how they really adopt those guidelines and go forward. So IS is not a body of law. It is just an academic body which can give the academic guidance. But to enforce it, to implement it, I think it depends upon institution to institution as well as the personal person who can always go ahead with the adoption of those guidelines. We are basically for the patient safety, these guidelines are there.
Yes, even in ICU it is not available. ABG is available, but capnography is very difficult to get that facility everywhere.
Yeah, that's true. That's also true.
Yeah.
That's why I told this project, if anybody is good in innovation
Yes,
and
mobile capnograph and all.
you come with the portable model of the capnography, and we will be able to go ahead with that formation of portable mobile ETCO2 monitors. I've given open invitation to everyone who can really be part of that innovation cell. If they have something, they can prepare a draft and they can come to the national headquarters is by email. So we can go forward in developing that portable model, which with the help of the engineering as well as with electronic companies, and we can go ahead and distribute to the entire country also with a with that no profit, no loss basis. We can do that also, sir.
Yes, sir. The laparoscopy surgery is very common nowadays, and it should be available for us. Yeah. Thank you, sir.
Yeah, welcome, sir.
Thank you, sir.
Now, time to leave. I thank everyone who was present right from the beginning and also listened to the class. And hope to that this class will be etched in your mind for a long time. See you next week, next Monday at 6:30 p.m. Till then, goodbye from the ISA National Headquarters. So, and by saying, long live ISA.
Long live ISA. Long live ISC.